Yes, sir. Yes, sir. Yes, sir.
Yeah. So thank
We can
you,
hear you.
Sahu and Gangadhar, for this opportunity. And it's a pleasure and privilege to be here. In the next 20 minutes or so, I'm going to be talking about what exactly is sepsis-associated AKI, a brief overview of the pathophysiology, and how does it actually impact my management of sepsis and the factors that we need to be cognizant of when we integrate the management of sepsis in AKI. The most common issues being fluid resuscitation, vasopressor therapy, and a little bit about organ support. And the question is, sepsis comes and goes, but if you do have an AKI, does that have a long-term impact on patients? That's something that I think we need to be aware of. And are there any novel therapies for this particular entity? And that's the kind of flow that I'm going to take about. So what exactly is sepsis-associated AKI? Sepsis, all of us know, has a very good definition, the sepsis 3 definition, that tells you that there is a dysregulated humoral response and an immune response that happens because of an infection. We also know what AKI is. The definitions of AKI have evolved over a period of time, and currently we do go by the KDIGO guidelines that was referred to by my previous speakers. So till recently, we did not have a good definition for sepsis-associated AKI. A recent meta-analysis actually looked at it and said there were 4 different definitions, and there was no consensus among what exactly is sepsis-associated AKI, and there has been a huge variability in the epidemiology of sepsis-associated AKI. Not only that, we also don't know what exactly we mean when I say sepsis-associated AKI. Therefore, to study interventions or to try and evaluate biomarkers was becoming challenging. Till recently, what we used to say is if you have an AKI and you don't have an obvious cause except sepsis, then go ahead and call it sepsis-associated AKI, meaning the patient has to meet sepsis 3 criteria and KDIGO criteria, then we call it sepsis-associated AKI. And that's pretty much what we had done until now. More recently, this is just from 2 months ago, the AKI group basically got together and said that we need to be very clear in terms of how we define sepsis-associated AKI. They said that sepsis-associated AKI is any AKI that occurs within 1 week of the onset of sepsis. Why 1 week of onset of sepsis? Beyond that, it's unlikely that the sepsis itself was probably causing the AKI, and there could be other factors that could have led to the AKI. So the broad term used is sepsis-associated AKI. When I say sepsis-associated AKI, it means that the AKI could be directly because of the sepsis, or it could be because of several indirect insults that happen to the kidney. For example, you could have somebody with a lot of nephrotoxins, either in view of antibiotics, contrast, or whatever. It could be the drugs that we give, like polymyxin. It could be a rhabdomyolysis associated with the sepsis, or fluid resuscitation causing abdominal compartment syndrome. So all this, if it happens within the first 1 week, we would call it sepsis-associated AKI. But what we are actually interested in is sepsis-induced AKI. Did this sepsis induce this AKI? And that becomes extremely difficult to delineate. And sepsis-induced AKI is a major chunk of what we call sepsis-associated AKI. And what we need to first understand is that when we say sepsis-associated AKI, it is not always directly related to the sepsis. It also could be a collateral damage happening because of whatever is happening to the rest of the patient as a whole. So that's the point number 1 we need to be clear about. Point number 2, sepsis-associated AKI has been classified into early and late. If it happens within 48 hours, we call it early. If it happens between 48 hours to 7 days, we call it late. Why this classification? Because the implications are several. Number 1, there is excellent data to say that late onset AKI happening after 48 hours in a patient with sepsis behaves differently in terms of epidemiology and outcomes and long-term outcome. They generally do not do as well as early AKI. Early AKI seems to have a better prognosis. So that's one of the first reasons. And number 2, the therapeutic implications may be different. If I have to prevent or progression of early sepsis acute AKI, I need to focus on adequate resuscitation, good antibiotics, control the inflammatory response by doing good source control, maintain adequate perfusion pressures, and see if I can help the kidney. But if it's late AKI, all this is probably already done by day 3. And now I'm focusing on rest of the organ support and maybe minimizing fluid overload and causing damage to the kidney by avoiding those things. So the implications are different between early and late AKI. So again, to reiterate, when we say sepsis-associated AKI, we are bundling a whole bunch of stuff that we think is probably related to the sepsis. What happens if I develop AKI first and then develop sepsis later? I can have AKI first, and AKI itself can predispose you to sepsis. There is good studies to say AKI increases your chances of sepsis. Sepsis following AKI is not classified as sepsis-associated AKI. So sepsis has to occur first, and AKI has to occur within the next 1 week for us to call sepsis-associated AKI. So this is the current consensus based on the AKI. It gives us a little bit more clarity in terms of what we actually call sepsis-associated AKI. This is a very good meta-analysis that actually looked at sepsis-associated AKI. Not only they were trying to look at the epidemiology, they were trying to look at the risk factors of how somebody would develop sepsis-associated AKI. There are significant host-related factors. If you have a known hypertensive, known diabetic, chronic liver disease, CKD patient, and you're a smoker, the risks of AKI goes up. Then there is a disease-related, sepsis-related issues like septic shock, vasopressor use. If you are ventilated or if you have gram-negative bacteremia, the chances of you developing AKI go up. And others, I would say, if you are on a medication that inhibits the renin-angiotensin-aldosterone mechanism, like an ACE inhibitor or an ARB, the chances of you developing an AKI go up. So we kind of know who are all the patients who are likely to develop AKI based on this meta-analysis at this point of time. How does it actually occur? The traditional belief is that there is hypoperfusion to organs, including the kidney. Kidney is more pressure and flow dependent, and therefore we get AKI because of hypoperfusion. That is partly true. Yes, there is some amount of hypoperfusion in an under-resuscitated patient. Vasodilatation, decreasing your perfusion pressures happens. But the predominant mechanism of sepsis-associated AKI is microcirculatory, inflammatory, and mitochondrial dysfunction that happens. And if at all anything, studies have sometimes shown that there is plenty of blood flow to the kidney that happens during sepsis because of the vasodilatory response. And it is not because of lack of oxygen delivery that the kidney is actually failing. Like you get shunting in the capillaries across several areas, you can get the glomerulus being shunted in sepsis, that the blood can just go near the glomerulus, bypass it, and go on to the other side very easily, number one. Number two, you could also have what we call as DAMs and PAMs, damage-associated membrane proteins and pathogen-associated membrane patterns. These are all small molecules that can easily get filtered into the glomerulus. And there are receptors in the tubular epithelial cells that mimic your toll-like receptors. Once these DAMs and PAMs go and adhere to these receptors, there is a cascade of a whole bunch of inflammation that happens that predominantly causes free radical release, inflammatory pathways, complement activation, and so on, causing further injury. Severe vasodilatation occurs everywhere, but efferent arterioles seem to be more susceptible to the dilatation. Therefore, the intraglomerular pressure goes down, again decreasing GFR. So there are several mechanisms why this happens. And just a nutshell, like you say, once you have PAMs and DAMs, you get immunomodulation, inflammation, complement activation, renin-angiotensin dysfunction, mitochondrial dysfunction, metabolic problems, microcirculatory problems, and alteration. Any or all of this can combine together to cause AKI. So when I say sepsis-associated AKI, a person may have only inflammation and mitochondrial dysfunction. One may have perfusion and metabolic derangements. So it's very difficult to categorize all septic AKI into the same pathophysiology, and multiple endotypes can join together to form what we call a subsequent phenotype of the AKI. And once insult happens, we also have to look at how resistant as an organism you are in terms of to the inflammatory pathway. Can your cells resist the damage from the inflammation to happen? And if the damage happens, how much can your tissues tolerate? So there is so much genetic variability among individuals in the way the inflammation happens, the tolerance happens, and resistance happens. The manifestation of septic AKI can be myriad and becomes extremely difficult for any a clinician or a researcher to say, pinpoint and say, this is the kind of category of septic AKI I'm going to study. So with that kind of a complexity, what can I do at the bedside to try and see to help the patient and minimize bad outcomes? Let's talk about each of the common things we would do in sepsis: fluid resuscitations, maintenance of mean arterial pressure, and organ support, like I said earlier. The first question I want to put forth is, does fluid therapy actually prevent AKI? Renal ischemia theory is challenged. I just showed you a whole bunch of mechanisms where renal ischemia does not have to happen, and you can still have AKI. Renal ischemia is too simplistic. There's a lot of inflammation and microcirculatory alterations, which we have absolutely no way of modulating at this present point of time. Fluid responsiveness is unpredictable. Even if I gave you fluid, it doesn't mean you will improve your cardiac output because of various factors. Studies have shown, including the FACT study, showed that only about 30% of the patients are actually fluid responsive when you actually do it in the ICU. Even if I am fluid responsive, the responsiveness is not going to last long because of the capillary leak. The moment the capillary leaks, the fluid I give is going to go out and my intravascular volume is going to go down, and whatever effects in the hemodynamics I saw is going to be transient. So that becomes important. We need to understand that giving a fluid bolus itself can worsen capillary leak. I will allude to it a little bit later when we talk about fluid overload in this particular population. And fluids do not correct vasodilatation. So that's something that we need to be careful about. So what do we know about the study so far? The only EGDT study that actually looked at the incidence of AKI was process study. Almost no difference in the incidence of AKI between the groups that got EGDT and the control group. No mortality benefit. On the other hand, there are several studies that have shown that if I do a lot of resuscitation and my central venous pressure is high, my mortality goes up because of venous congestion, and my AKI goes up because of renal venous congestion also happens. This is a very elegant study where they classified patients into initial fluid resuscitation and subsequent fluid resuscitation. If the initial fluid resuscitation was adequate, but subsequently was conservative, you see the lowest mortality. All the other groups, even if the initial is inadequate and liberal, you have a very, very high mortality. So there is some argument that probably we need to be careful in terms of how we resuscitate patients in sepsis, and just the argument saying I'm going to protect the kidney probably doesn't hold good. The other end of the spectrum, if I give too much fluid, I'm going to increase my mortality and increase my creatinine. This is the most quoted paper, the Picard paper, where they clearly showed that if you have a more than 10% weight gain, there is substantial increase in 30-day, 60-day, and hospital discharge mortality. Not only that, there was a very nice dose-response relationship. More the fluid overload, more likely you're going to die. More the fluid overload, more number of days you are fluid overload, you're going to die. And CRRT was slightly better than intermittent dialysis in this particular study in trying to attenuate and remove the fluid. And we need to be careful about how much fluid and how fast we give, because anytime we give fluid bolus, there is atrial distension and natriuretic peptides are released. And these natriuretic peptides go and damage endothelial glycocalyx. One endothelial glycocalyx is damaged, the capillaries become leaky, and this vicious cycle of more fluids, leakiness, and relative hypovolemia continues, and we end up with fluid overload and the consequences of fluid overload. So clearly, fluid therapy on one end has not been shown to improve the AKI. On the other hand, clearly it looks like it can hurt the kidney by giving too much, increase venous pressure, increase intracapsular pressure, and a lot of other things that can actually worsen the kidney function in patients with AKI. Fluid accumulation also can dilute the serum creatinine. And this is a very nice study where people showed that fluid accumulation dilutes the serum creatinine. Therefore, you seem to think that the creatinine is not elevated, probably because the creatinine is diluted with all the fluid overload that we have created. And our diagnosis of AKI becomes late and also probably delayed, and our interventions do not work as well too late. This is the most recent Clover study where they looked at early restrictive and liberal fluid for sepsis-induced hypotension. What they actually found was that early restrictive fluid with vasopressor did not change initiation of renal replacement therapy or the KDGIO score at 3 days in this particular subgroup. This is the most recent classic trial, again, restricted versus liberal fluid therapy. As you can see, the presence of AKI, 47% in both the groups, severe AKI, 23-24% in both the groups. Clearly no difference between both the groups in terms of restrictive and liberal fluid overload. So clearly hypovolemia is bad, clearly hypervolemia is bad. We need to find a fine balance in terms of AKI and mortality. That would be $1 million question at this point of time. And we need to be careful also about what fluid we give. One, the quantity of fluid needs to be careful in patients with sepsis and AKI. We also need to be cognizant of what type of fluid do we need to give. So what fluid should I give? Should I give colloid or crystalloid? This is the CRICO study looking at hyperoncotic colloids compared to crystalloids and hypooncotic colloids, clearly showing that hyperoncotic colloids like 20% albumin and starch solutions clearly increase the renal events, renal dysfunction, need for renal replacement therapy, and increase mortality. The mechanism of this is hyperoncotic colloids decrease your GFR because they are holding on to the fluid inside the blood vessel without allowing fluid to go across the capillaries. And remember that glomerulus is a capillary. Therefore, these fluids, in essence, simplistically decrease the GFR and worsen outcomes. How about regular albumin? This is the analysis from SAFE study. No difference between albumin and saline in terms of RRT or mortality. So whether you use isotonic crystalloid or albumin, there is no change in terms of the acute kidney injury or the need for dialysis. So the moral of the story here is avoid hyperoncotic colloids, which is predominantly 20% albumin as a resuscitation fluid. Starches, several studies, the YSEP study first, 6S study, and subsequently the CHEST study clearly showed that starch solutions increase the chances of acute kidney injury, increase the need for dialysis, and increase mortality, and therefore clearly are not recommended anymore and have been withdrawn from both the US and the European markets and are not in favor in terms of resuscitation. What about crystalloids? Normal saline had been the default crystalloid that's been used. Consistent data has shown that chloride is bad for your kidney. Hyperchloremia hurts you by causing adenosine release and therefore causing renal vasoconstriction. And this could be potentially harmful to the kidney. This was evaluated in several studies, the UNO, SPLIT, SMART, and SALTED. Unfortunately, none of them have equivocally shown balanced crystalloids to be better than normal saline in patients with sepsis and AKI. But remember that most of these studies gave very little volume, 1 to 1.2 liters of fluid, probably not enough to impact. If you look at their chloride differences, it was hardly about 2 to 3 milliequivalents per deciliter between the two groups. Again, not significant hyperchloremia enough to cause outcome differences in these studies. And the biggest confounder was that in almost all of these studies, before randomization, patient had got all kinds of fluids, and there was a lot of dilution of the results that happened. The biggest study that evaluated the balanced crystalloids is the BASIC study. Again, predominantly surgical patients, no difference in 90-day mortality or acute kidney injury in these particular patients. Again, patients got about 80% of the patients got an alternate fluid prior to randomization, which could have diluted the effect. This is the most recent study, again, looking at the PLUS study, balanced versus normal saline. No difference in AKI, no differences in any of the outcomes, even in sick patients. The BASIC study, which I had quoted earlier, were very, very less sick patients. The Apache score was only 12. 12 is somebody who's probably in the step down or walking on the road. So you don't really feel that any fluid is going to do significant damage to them. But this study is Apache more than 25, happened in about 1/3 of the patients. This is the kind of patient you and me would see in the ICU. Absolutely no difference in any of the renal outcomes, despite giving balanced crystalloids. Again, patients got both fluids prior to randomization that could have diluted the effort. So what is the drive-home message at this point of time? I would say in septic AKI, prevent hypovolemia, avoid fluid overload, try to use dynamic measures and all the hemodynamic monitoring available to you to try to come to a decision about fluid responses. Be very, very careful about your use of fluids. Do not do it in a knee-jerk reaction. Avoid hyperoncotic colloids, avoid starch solutions. Data is equivocal or probably negative at this point on balanced crystalloids, but I think all of us would agree hyperchloremia is bad and try to avoid hyperchloremia going in. What about the blood pressures? This is a very nice physiological study where they looked at the episodes of mean arterial pressure of less than 60 seem to correlate with death in patients with sepsis. However, if you want to prevent renal replacement therapy, they suggested that the cutoff seems to be a higher mean arterial pressure of somewhere around 75 millimeters mercury. This is a sepsis spam study where they randomized patients into a lower MAP and a higher MAP of 75 to 80 versus 85 to 90. Found no difference between the two groups. However, in patients who were hypertensive to start with, the higher blood group had lower incidence of acute kidney injury and renal replacement therapy. On the other hand, if you used a higher dose of vasopressor to maintain a higher mean arterial pressure, these patients had a lot of arrhythmias, and that needs to be balanced with the benefit that you would get from increasing the mean arterial pressure to 75 to 80. There is some data to say vasopressin may be renoprotective. The first one is the VAST study in patients who got vasopressin. The incidence of AKI, the progression of AKI, and the need for renal replacement therapy were lower in the subgroup analysis. Similarly, in VANISH study, the need for renal replacement therapy was lower in the vasopressin group. Probably because vasopressin is a more potent efferent arteriolar constrictor, therefore increasing your GFR. And at this point of time, we have only 2 subgroup analysis, hence we don't have definitive data. Ongoing trial is currently looking at the role of vasopressin in AKI. Hopefully, we'll have answers in the next few years. So in terms of vasopressors in septic AKI, vasopressin may have renoprotective efforts. There is good physiological rationale, good signals in post-hoc analysis, but no conclusive evidence. If you are a known hypertensive, keeping a slightly higher MAP may be worthwhile to prevent acute kidney injury. But remember that that increases the chances of arrhythmias, and this risk need to be balanced against the benefit of the vasopressors. What about other organ support? Invasive ventilation itself is a risk factor for acute kidney injury. Most of the septic patients are ventilated. Ventilator itself creates a sympathetic drive that causes vasoconstriction, therefore worsening acute kidney injury. This is independent of the tidal volume or the pressures you set on the ventilator. That has been very clearly shown. And there is also some data, experimental data, to say permissive hypercapnia could be bad to the kidney because it is a potent vasoconstrictor when it happens in the kidney. So yes, there are benefits of permissive hypercapnia to the lung, but we need to be careful about permissive hypercapnia to the kidney. How about renal replacement therapy? Should I do it early or late? This is the AKI trial. The reason I picked the trial is the earlier trial, the ELINE trial, had only surgical patients. In this trial, about 2/3 of the patients had sepsis and septic shock. They randomized the patients to early versus late dialysis. No difference in survival, no differences in the receipt of renal replacement therapy. However, an important point is that almost 50% of the patients who were randomized to late renal replacement therapy never needed dialysis. They got better without dialysis, and maybe making us think, are we rushing into dialysis very early in this kind of patients? This is the ideal ICU study, which looked only at patients with sepsis and AKI, again, early versus late. No difference in outcomes between the two groups. Again, about 30% of the patients randomized to the delayed group actually never received dialysis, and they actually got better without it. Early dialysis group had increased CRBSI, and we need to be careful about jumping into dialysis early in these patients, because at this point of time, there is no good evidence to say that. What dose of dialysis should be used? When it comes to sepsis, the most quoted study would be the Ronco study, where he randomized patients to 25, 35, and 45 ml per kilo per hour of CRRT dose, and found that 35 and 45 were superior to 25, but 35 was equal to 45. So based on that, people believe that 35 ml per kilo per hour may be better than 25 ml per kilo per hour in septic patients. This was cross-checked in 2 trials, the renal trial that happened in Australia, New Zealand, and ATN trial that happened in US, where they randomized patients to 25 versus 35. Both the trials did not find that the higher dose of renal replacement therapy had any outcome benefits compared to conventional dosing of RRT. So organ support, invasive ventilation increases the risk of progression of AKI. We still don't know whether it's a cause or effect. Tidal volume and PEEP don't seem to affect this. Permissive hypercapnia may have adverse effects on AKI. Renal replacement therapy, early versus late. No data to say early is better. On the other hand, patients who are randomized to late somehow get better without dialysis. So maybe we are jumping and doing dialysis on too many people too early. So we need to be cognizant. At this point of time, the optimal timing of dialysis in AKI is very, very unclear. In terms of dose, the only study that looked at septic patients was the Ronco study, but that study had been refuted by the other 2 studies, but there is no data specific to sepsis-associated AKI. So what happens to sepsis-associated AKI or any AKI? Once you develop AKI, you could either undergo repair and become normal, or you don't undergo repair and you kind of get into scar tissue. If you're going to repair well, the epithelium proliferates, the endothelium proliferates, the density of the peritubular capillaries become normal again, and your kidney becomes brand new. all over again, and you're fine and ticking and you're going along. On the other hand, if you have maladaptive repair, your epithelial tissues are atrophied, you have persistent loss of tubular function, you have a lot of fibroblasts, both in the tubular side and the interstitial side, causing scarring, and endothelium does not proliferate. Therefore, your peritubular capillary density goes down. All of this slowly adds on to worsening injury of the kidney. And if a second insult or a third insult happens, you could progress to CKD over a period of time. So considering all this, people have now looked at the classification and added some new categories. I told you about sepsis-associated AKI happening from the time of onset of sepsis within 7 days. If you fully recover, you're perfectly fine. If you don't recover fully, you can have partial recovery or no recovery. If you continue to have acute kidney injury between 7 and 90 days, we call it acute kidney disease. And anything above 90 days, we call it chronic kidney disease. So if you do not improve, by then you call it CKD. After the first week, you call it acute kidney disease. And this acute kidney disease, again, can become fully recovered or proceed on to CKD, depends on the number of insults you do have. Do we have any medications to address sepsis-associated AKI? The only drug that seems to be promising, we need more data. Dr. Osterman mentioned this earlier, is recombinant alkaline phosphatase. Recombinant alkaline phosphatase seems to dephosphorylate the endotoxin molecules and thereby seems to work. The primary outcome here was 7-day incidence of acute kidney injury. There was no difference between the two groups, but the mortality was lower in the group that used recombinant alkaline phosphatase in sepsis-associated AKI. So we probably need to look out for more data on this particular drug. It's exciting. We just have to wait it out and watch over the next few years. So to conclude my talk, management of sepsis has to be tailored and customized in the presence of AKI. Avoid both hypovolemia and fluid overload. Thoughtfully give fluids rather than a blind knee-jerk reaction. Avoid hyperoncotic and starch solutions. This statement is unequivocal. Avoid hyperchloremia, although the data on balanced crystalloids is not yet strong. Maybe we should target a map of slightly high 70 to 80 in hypertensive patients. Again, see if they're able to tolerate the higher dose of vasopressors without arrhythmias, and then decide for yourself. Vasopressin may have some renoprotective effects, but it's all based on post-hoc analysis, and we need to look at further larger studies to see whether this is actually true. Invasive ventilation itself increases the risk of AKI. So ventilate them like how you would ventilate ARDS with the least amount of lung trauma and inflammation that you can probably trigger from ventilation. In terms of dialysis, optimum timing is unclear. Early aggressive RRT may be potentially harmful. There is no data that it would help, and there is increased chances of CR by BSI, hypotension, and electrolyte abnormalities. The dose of renal replacement therapy at this point of time has to be similar to non-septic patients. We do not have any specific data for that. AKI can have long-term impact on renal function and recovery, as I told you. And let's all look out for further studies in recombinant alkaline phosphatase and hope that we would be able to do something useful to these patients in the coming years. Thank you so much for your patient listening. And I once again want to thank